Now, this is the next exciting step that's happening. Another combination that's very, very potent against genotype 1 hepatitis C. And this is not FDA approved yet. Do we know when that's going to happen there, and when the decision is going to be made? Do we have a date yet set or not? It was going to be December 10th. Anyway, I think it's moved up a little bit. I'm not sure. So anyway, this is what's called the 3D regimen. It's easy to remember 3D. I can't tell you what PTV stands for, even though it's online. But someone told me I can't say that name. I said, okay, fine, I can't say that name. So PTV is actually ABT450, which is a protease inhibitor. The small r stands for ritonavir, which boosts the ABT450. Then it's ombitosvir, dasabuvir, and ribavirin. So it's called a 3D regimen when there's 5 Ds there. 3D stands for 3-drug regimen. And the 3Ds are the 3 DAAs, direct-acting antivirals. So that's the ABT450, the ombitosvir, and the dasabuvir. They are the antiviral, anti-Hep C components. So those are the 3 drugs that are active against Hep C. The other 2 are kind of booster drugs. And you say, ribavirin, is that a booster drug? Well, ribavirin has very little direct anti-Hep C activity. So it seems to actually work to prevent relapse through other mechanisms than an antiviral mechanism. But anyway, so this regimen is another regimen that's on the way, and probably within a month or 2. So there are, again, registration trials for this regimen. And this is all published data. Most of it's in the New England Journal. The studies that were done with this regimen also are very impressive. And they show for genotype 1 treatment-naive patients on the left and genotype 1 treatment-experienced patients on the right. These were both studies were in patients without cirrhosis. And what's shown is the 2 subtypes of genotype 1, genotype 1A and B. And you can see here, it's really, amazing SVR rates again. It's kind of amazing when you talk to me. I mean, I was happy when we got 5% SVR rates, 20 years ago or so. If I got a cure of any disease, it was pretty amazing. Now we're talking about close to 100% cure rates. Then there's the Pearl 2, 3, 4 studies. And they examined whether ribavirin was really needed in the regimen. And if you look at the different studies, Pearl 2 and 3, Pearl 2 was genotype 1B treatment experienced, and Pearl 3 was genotype 1B treatment naive. And ribavirin isn't necessary there. On the other hand, Pearl 4 got a little bit higher rates when ribavirin was added. That's the blue bar, 97% versus 90%, than when ribavirin wasn't there in the 90%. So it looks like for genotype 1A that ribavirin may be necessary to augment the activity to make it optimal for genotype 1A. It's probably not needed in general for genotype 1B. Now, this is a very important study because it's the largest study which is focused completely on cirrhosis. The entire study was in patients who had been previously treated and also had compensated cirrhosis. Again, it's the compensated cirrhosis. It's not patients with real sick liver disease. And this did not look at ribavirin at all. Both arms got ribavirin. The only difference here was, was 12 weeks sufficient, or do you need 24 weeks? And in both the circumstances, 12 weeks versus 24 weeks, very high SVR rates, 92% versus 96%. Now, I'll give you some, in terms of the details of this, if we look at the genotype 1A population in here, in this Turquoise 2 study, the drop-off in response rate was pretty much restricted to the patients whose previous treatment was not very effective. They were null responders. So other than the null responders, everyone else seemed to respond pretty well to it. This is another combination that is coming along. It's a little further away. We're probably looking at middle to late next year. This is a combination of acinoprovir, decladisvir, and a drug that just has a number so far. And it hits the three components to the cycle, as did the previous combination. That is the protease, the NS5A protein, and the polymerase. And it too is showing some very good responses, maybe not quite as high as what we've seen with the other regimens that I've described, but this is moving forward into phase 3 studies, so we'll get more information on that over the next year. This combination was the first combination of ribavirin-free, interferon-free therapy approved and marketed in Japan. And because in Japan, it's basically genotype 1b infection. And even though the response rates weren't quite so robust with it, it far exceeded some of the other options that were available. So this actually was one of the very first interferon-free, ribavirin-free regimens to be used in the clinic in Japan. Now, getting back to our friendly Jacobs here in the front, I think even though this has been pretty heavy on clinical data and stuff, I do think patients need to be aware of this potential for drug-drug interactions. And that's why it's extremely important to have someone working with your team that understands this. And for physicians in practice who may not have a clinical pharmacist in their clinic, there are some very outstanding resources that they can turn to, where you can plug in, okay, I'm on Crestor. You know, what's the interaction with this Hep C drug that I'm being prescribed, so on and so forth. And there's definitely ways that your doctor or your care provider, mid-level provider, there's resources out there they can access to check on these drug interactions. So the important thing here, of course, is that I've told you about a lot of progress, the fact that we now have really leaped into the air, if you will, with extraordinary effectiveness and cure rates that could exceed 100%. But the trouble is, we got to land this baby, right? We got to bring this home so people can actually benefit from the therapy. And there are obstacles. And this is some of it, and you've heard about it in the newspaper, is cost. And hopefully with competition, we're going to see some improvement in these costs. And of course, every major newspaper in the country made some statement related to cost when sofosbuvir was released. But the thing that our payers and our, whether it's Medicare, Medicaid, private insurers, there is a cost of not treating chronic hepatitis C, right? So just look at this. This is a little summary that Don Jensen put together with Nancy Rue out of Chicago. And the overall healthcare cost per patient related just to hepatitis C diagnosis is around $24,000. That's for the whole hep C population per patient. Annual cost per patient without cirrhosis, of course, is lower at $17,277. Annual cost once you get compensated cirrhosis, $22,752. Annual cost once you get end-stage liver disease, $60,000. And if you need a transplant and 1 year of care thereafter, you're looking at $600,000 in care. So now the cost of a cure doesn't seem so costly. However, we still have to deal with this as an issue. So what's happened is the payers are trying to determine who to treat and setting up schema like this. So priority list for resource allocation. So how do they allocate money for hep C therapy? Well, the professional societies are on top. AASLD is the American Association for the Study of Liver Disease. That's like people like me, liver doctors. And the IDSA is Infectious Disease Society of America. Those are infectious disease experts. And basically, neither of those societies have really provided a priority list. There's some action in that the last year, but prior to this year, really not much. EASL had one based on fibrosis stage. That means if you had more fibrosis, you needed treatment first. So we had to put together an advisory committee here, and we set up a priority list, which in some ways was good and bad. Whenever you do a priority list, some people think it's an exclusionary list or only an inclusionary list. And so what happens is they focus only on the top of the list and not everything underneath. And one of the things I think that you can help yourself with on this is I think the exclusions related to alcohol use. If you're drug using and not involved in a treatment program, it's going to be to your disadvantage to try to get treatment, I can tell you that. All right, so I hope we've learned one thing, that this disease is now curable in almost every patient. Not every patient, but almost every patient. These treatments are highly effective and very well tolerated. It's very important to me, number one, for you to understand how important it is to define your severity of disease, particularly identifying cirrhosis. It's also important to work with your team of providers so that we need to identify and manage drug-drug interactions. The biggest pain with this treatment may be paying for it, because the treatment itself really lacks side effects. But clearly we've got to figure out ways, innovative ways, to come up with ways to cover this extraordinary page in medicine. I mean, and this is a chapter in medicine that I think historically in the future will come down as a really amazing biomedical achievement. We just have to translate it to a clinical achievement. Yeah, which takes time. Yeah, thanks a lot. So why don't we, Jacob, why don't you come up here, and if you heard this talk, so do you have anything to say about anything at all?
Anything at all. All right, well, thank you. Like Dr. Everson said, is that I work in the clinic from more of a pharmacy standpoint, so I help with patients looking over, making sure that we know exactly what they're taking. One of the important things I always emphasize is when we talk about medications, we're talking about prescribed medications. We're also talking about herbal supplements, vitamins, over-the-counter medications, basically everything that you're putting in or on your body. Because those also have interactions. And a lot of times people with herbal supplements, you think natural, you think safe, and that might not be the case. And so it's really important that when you're going to see either it's your hepatologist or just your primary care provider, to make sure that they know exactly what you're on. And to ask them, you know, if that really is the best treatment for you. And so then one of the things is that I also help coordinate with our pharmacy, trying to get patients on treatment as quickly as possible and get it paid for by someone. And that can definitely be a challenge, as Dr. Everson said. The price is high, and no one can deny that. It's a high cost, and so certain insurance companies have set up different standards, saying we will do this. We're going to not cover that. Yep.
Jacob, you educated me on the double donut. The double donut hole. Have you had that happen to anyone out there? The double donut hole.
So
who's hit the donut hole? Yeah.
Yep.
Someone actually hit the donut hole over there. What about the double donut hole? Has anyone hit the double donut hole?
Yeah. So
tell us about the double donut hole.
Donut hole. So the double donut hole is going to be for our patients who are starting treatment as soon as possible. Some Medicare Part D plans have been doing a great job of covering. One of the issues with Medicare Part D is that as people who are familiar with the plan call it the donut hole. And so what it is that Medicare Part D will cover part of the prescription costs, any prescription costs, not just Hep C prescriptions. But what they do is they cover part of the cost until you reach about $2,500. After that, there's this coverage gap. And the coverage gap is where 100% of the costs are on the patient. And usually that's a couple $1,000s, usually about $5,000. After that, they go into what's called catastrophic coverage. And that's where the majority of the costs will go back to the insurer, not on the patient. And so depending where we're right now in the end of October, let's say we were to start a patient today, If they previously had been on higher cost medications, they might have already been in the donut hole or maybe even past the donut hole, depending on what they're on. But if they weren't taking other medications, haven't hit the donut hole, they're going to hit it the moment we set that first fill. Then as we go, January 1st, that completely resets, so we hit another donut hole. And so that's where we kind of hit the double donut hole. And so for some of our patients with Medicare Part D, we do have different advocacy organizations and different organizations that might help with co-pays, but we're going to have to wait until January 1st before we can really start that. That way it's all going to be within the same year and we won't hit both of those. And so sometimes it's a matter of really figuring out exactly what's going on with the insurance, looking at the entire coverage, and figuring out what is going to be the best and cheapest option for our patients, and when exactly we can start. And ideally, we'd love to start every single patient in our clinic tomorrow. Realistically, it's a little bit of finesse and working with the insurance companies. A lot of times there's also organizations that can help cover co-pays, and really just trying to maybe use different resources from different pools to get a total cost for the patient.